All right, let's talk about inherited thrombophilias in pregnancy, background, hemostatic paradox of pregnancy, increased clotting potential, decreased anticoagulant activity, and decreased fibrinolysis. Patients are Pregnant patients are 5 times more likely to have a VTE compared to non-pregnant patients. VTE complicates 2 out of 1,000 pregnancies, and 10% of pregnancy-related mortality can be attributed to VTEs. Prevalence of common inherited thrombophilias. So there is 1, 2, 3, 4, 5, 6. Factor V Leiden mutation, prothrombin G2210A, protein C, protein S, antithrombin, and MTHFR. So for factor V Leiden, 5% in white people and 2% Hispanics. So the factor V Leiden is refractory to proteolysis by activated protein C. Heterogeneous factor V Leiden account for 40% of VTE in pregnancy. Homogeneous women with no personal history of VTE have 1% risk of VTE during pregnancy. With the history of VTE, it goes up to 20%. Prothrombin G20 to 10A, 3% in white and Hispanics. If history of VTE in the past, pregnant women who carry this mutation have a 10% risk of VTE versus 20% before. Protein C deficiency, 2% of VTE risk during pregnancy. The fetus can also have something called neonatal purpura fulminans, things like skin peeling after delivery. These babies needs lifelong anticoagulation. Protein S deficiency, about 5% risk of VTEs. They can also have babies with neonatal purpura fulminans. Antithrombin deficiency, 40% chance if history of VTE and severe antithrombin deficiency, as in the antithrombin activity is less than 60%. If there's no history of VTE, these patients have 10% risk during pregnancy of VTEs. MTHFR has no increased risks. Adverse pregnancy outcome, fetal loss. There's no benefit to start prophylactic heparin or ASA in these patients to prevent fetal loss. Screening for inherited thrombophilia is not recommended in the setting of stillbirth. Also, there is no association with preeclampsia, no association with FGR or placental abruption. So anticoagulation for prevention of adverse outcome is not recommended because they're not associated with anything, just the VTE risks. Clinical consideration and recommendations. So who are candidates for thrombophilia evaluation? So if the patient has personal history of VTE with or without recurrent risk factors, and They have not had a thrombophilia workup before. You can test for factor V Leiden, prothrombin, the G21 mutation, antithrombin deficiency, protein C, and protein S deficiency. We can check APS as well. Testing should be remote from any thrombotic events. More than 6 weeks. Patient is not pregnant and not taking anticoagulation or hormone therapy. Screening for MTHFR mutation or fasting homocysteine level is not recommended. Um, first degree relatives with history of high risk inherited thrombophilia, we can have this patient do a targeted test for the specific thrombophilia. Anticoagulation for prevention of VTE. We can take a look at table 3. Oh crap, I gotta log in. Thrombophilias in pregnancy. Let's see. Table 3. Okay, so what are the high-risk thrombophilias? So factor V Leiden, homozygous, prothrombin gene G2210 mutation, homozygous, or if they're heterozygous for factor V and prothrombin G2210A, or if they have antithrombin deficiency. So these are high risks. So clinical scenario, low risk thrombophilia without previous VTEs. These patients do not need anticoagulation antepartum, and in postpartum there you can do surveillance without anticoagulation, or if they have additional risk factors in postpartum, they can be started on prophylactic anticoagulation. And then so risk factors as in obesity, prolonged immobility, and C-section. Low risk thrombophilia with family history, first degree relatives of VTE. These patients should be, we can do surveillance without anticoagulation therapy or prophylactic heparin. And in antepartum and then in postpartum, these patients should be on a prophylactic anticoagulation therapy or intermediate dose heparin. Next will be low risk thrombophilia with a single previous episode of VTE, and they are not on long-term anticoagulation therapy already. These patients should be on a prophylactic or intermediate dose of heparin. Postpartum prophylactic anticoagulation therapy or intermediate dose heparin. So, and then now we're in the high risk category, high risk thrombophilia without prior VTE. They should be at least in antepartum, they should be on prophylactic or intermediate dose heparin. Postpartum, they should be on prophylactic or intermediate dose heparin. So, intermediate dose for both. High-risk thrombophilia with a single previous episode of VTE or affected first-degree relatives, and they are not already on long-term anticoagulation. These patients should be on prophylactic or intermediate dose or adjusted dose. So anything for these patients. Postpartum, same thing. Anything is fine. But there should be at least matching antepartum dosing. Alright, next is thrombophilia with 2 or more episodes of VTE not receiving long-term anticoagulation therapy. These should be at intermediate or adjusted dose heparin. Postpartum, they should also be on intermediate or adjusted dose for at least 6 weeks. So these should all be at 6 weeks. So next is thrombophilia with 2 or more episodes. They are already on anticoagulation therapy. They should still get adjusted low molecular weight heparin. Resumption of long-term postpartum. They should resume their long-term anticoagulation therapy. Oral anticoagulation should be considered postpartum based on planned duration of therapy, lactation, and patient preference. So going back to the woman on prophylactic dose of heparin should continue 6 weeks postpartum. The anticoagulation regimen is low molecular weight or unfractionated heparin. Both can be used during pregnancy because they do not cross the placenta. Low molecular weight heparin is preferred. So also these two are safe for breastfeeding, and so is warfarin. Antithrombin concentrates can be used in antithrombin deficiency patients refractory to standard anticoagulation therapy. Initiation of anticoagulation should be upon confirmation of viable pregnancy. Peripartum management, therapeutic low molecular weight heparin should be stopped 24 hours before induction to allow neuraxial anesthesia. Prophylactic low molecular weight heparin should be stopped 12 hours before induction. If the unfractionated heparin is used and is greater than 7,500 units, it should be stopped 12 hours before, and we check a activated PTT level. Patient receiving anticoagulants should stop injection at the onset of labor. If rapid reversal is needed, we can use protamine sulfate. However, it only partially reverses the low molecular weight heparin. Postpartum anticoagulation can be restarted 6 hours after vaginal delivery or 12 hours after C-section. Starting warfarin postpartum needs bridged with heparin until INR is 2.5. Let's look at the regimens real quick. So prophylactic dose of um, low molecular weight heparin is enoxaparin 40 milligrams sub-Q once daily. Intermediate dose is Lovenox again 40 milligrams sub-Q BID. Adjusted dose is low molecular weight heparin or Lovenox 1 milligram per kilo every 12 hours. So for the unfractionated heparin, prophylactic dose is 5,000 to 7,500 sub-Q Q12 in the first trimester, up to 10,000 units in the second trimester BID, and continue into the third trimester. I guess you check PTT as well to make sure it's not elevated. Adjusted dose heparin is 10,000 units or more every 12 hours. Adjust the PTT in the therapeutic range 1.5 to 2.5 times the control 6 hours after injection. Postpartum, alright, so 6 to 8 weeks. That's it.